Hello, everyone, and welcome back to the Core Console RX podcast. I'm Mike Corvino. With me, as always, is my distinguished co host, Cole Swanson. Today, we have a very special guest coming all the way from Chapel Hill, North Carolina, Jordan Miller. Jordan, what's up, buddy?
Not much. How are you guys doing?
Doing really
Doing
well.
great.
Good.
So, to give you guys some background, Jordan and I graduated together, and he was always extremely involved in school and very, very smart. And so I'm very excited to kind of reconnect with him. I haven't talked to him in quite some time, so I'm really excited to hear about what he's doing and let him share with you guys what he's been doing because he's kind of a rock star in the pharmacy world. So I'm really excited to have him on the show today. So Jordan, give us a little bit of kind of history. 2015, you graduated pharmacy school.
hmm
What happened after that?
So before that, I just want the audience to know that Michael Corvino consistently outperformed me on exams.
That is
So while
definitely not
his,
true.
so while his introduction is flattering, don't let him convince you that he's something he's not. But I appreciate that. Yeah, so I graduated in 2015 with Mike, MUSC. Um, And then I explored the Pacific Northwest, where I did my PGY1 residency in Portland, Oregon, at Oregon Health and Science University. That was a really good experience. It was one of the main reasons I chose there is because as PGY1s, they have you staff in like a clinical specialist role. So I was responsible every other weekend covering about 70 patients clinically, doing all their notes, rounding, and all of that stuff. It was a lot to learn, but I grew a lot from that experience. I kind of knew in pharmacy school and going into PGY1 that I was interested in oncology. As a student, I had a rotation at MUSC in oncology. I did a pediatric oncology rotation at St. Jude specifically. And that was when I first was introduced to hematology or blood cancers. So going into my PGY1, I knew I wanted to set that up so that I could have some more exposure into that. Because my St. Jude rotation was my favorite one I had had, but I didn't know if it was because I liked pediatric oncology or I liked hematology. So as a PGY1, had adult hematology and adult bone marrow transplant, and fell in love with those. So I knew I wanted to do a PGY2 in oncology, and had a program where I would get a lot of experience in hematology and bone marrow transplant. So that's what led me to doing a PGY2 in Chapel Hill at the University of North Carolina. We have a lot of specialists here in the outpatient setting. So we have a pharmacist, all he does is the leukemia clinic, another, all they do is the breast cancer clinic, and so on. And we have a pretty good sized bone marrow transplant program with rotations inpatient and outpatient. So I was fortunate enough to match here, finish my PGY2 residency here in June of 2017. And then I accepted a job. My first job was at the Cleveland Clinic in Cleveland, Ohio, as a bone marrow transplant specialist. Specifically, I was hired to help them establish a clinic in the outpatient setting. They didn't have a bone marrow transplant pharmacist there, only on the inpatient side. So having had a lot of experience at UNC in the clinic setting, and learning from the pharmacists here on how they took a clinic that had zero established pharmacy services, and then now have a very robust pharmacy service. I took those ideas there and helped them implement that into their clinic. My wife is from North Carolina. I'm from out west, and I always knew eventually if an opportunity came up in one of these locations, it would be hard to say no. An opportunity came up much sooner than I was anticipating, so I'm actually back at UNC Chapel Hill now after spending about 6 months at the Cleveland Clinic. So I'm the outpatient myeloma and lymphoma clinical specialist here at UNC.
That's awesome, man. So, what was the big switch, or how did you feel the switch went from going from student P4 year? I mean, obviously, I remember you took really hard rotations, so you were probably used to a lot of work, high workload. But when you actually transitioned to a PGY1 resident, what was the
Mm-hmm.
was it a shock to your system? Was it okay? I kind of got this. I mean, it's maybe a little bit different for you because you've always been a hard
Sure.
worker, so I don't think you shied away from the workload. But was it shockingly different going to one to the other?
Sure. So I did my best, my P4 year to try and give me a residency like year, I took an extra rotation. I tried to have a really good range. I tried to pick preceptors that would challenge me. And PGY1 was extremely challenging still. It was really hard. I think the biggest shock, I wouldn't say like clinically, I didn't feel unprepared. I feel like I was at an appropriate level for someone who just finished school.
Mm-hmm.
There was a ton of stuff and still is like things I didn't know. But I think the biggest hill to overcome or the biggest thing to learn was just being comfortable with not knowing everything and knowing that notwithstanding that, if you develop other skills, you're still going to be okay. You're still going to get through the day, get all your responsibilities done, and take care of your patients well. So I developed a greater efficiency in working at my patients and making decisions for them. So I think, becoming comfortable with the unknown and the fact that you don't know a lot of stuff was probably the biggest shock, biggest challenge to overcome.
Gotcha.
Awesome. Talk a little more about setting up the bone marrow clinic. The patients, were they already in your health system, or did they hear about the clinic and they were referred to you guys, or how did all that work?
Sure. So bone marrow transplant is, just brief background, is essentially, so it's a potential cure for some hematologic malignancies when you get that transplant from someone else, which is an allogeneic transplant. Then we have autologous transplant, which I'll talk about briefly, later today, which is a little different. But it's a very involved process and requires an extensive preparation and research on the physician's part into the patient's history, into their social support. So they so coming to the clinic, these are things that the patients have scheduled many visits prior to coming into actually getting the transplant, and then after the transplant, they're followed closely at least for 100 days.
Right.
And they have to sign agreements that they'll live within a certain mile radius of the hospital in order to go through the transplant and so on. So these patients that were being referred to me were already established at the Cleveland Clinic. They already have bone marrow transplant dates set up. They have a donor set up. And the first service that I wanted to introduce was every patient prior to being admitted to the hospital for their transplant, I wanted a mandatory visit with a pharmacist. So during that time, I could, one, educate them a little bit about the chemotherapy that they were going to receive as part of their transplant, let them know everything I was going to do. Because I would build, I think both of you are familiar with Epic, like the electronic health record system. I'm sure a lot of the listeners are. And then if you've ever done anything in oncology within Epic, the system they use is Beacon. So my job, I built all of their Beacon plans to contain any order so not just their chemotherapy, but all the communication orders for the nurses, all their fluids, all, transfusion parameters, emergency medications in case they have any type of reaction, et cetera. So I would talk to the patient and let them know everything I was doing ahead of the game to prepare them, to prepare their admission. And then I would do a med rec, look for any potential drug-drug interactions, which often there were, because these patients come in with a history of cancer,
right,
and with immunosuppression, and often they're on antifungals like posaconazole or voriconazole, which are strong CYP3A4 inhibitors.
Right.
So there's a lot of coordinating that needs to happen on when to stop those medications, so they don't interact with their chemo, what we'll do on the inpatient side to continue to prophylax them with an antifungal, and develop that whole plan. So there's a lot of stuff that goes into coordinating their admission. So the first recommendation I had was to make it mandatory they meet with a pharmacist there. And then we were starting, prior to me leaving, was as soon as they're discharged, to meet with a pharmacist as well, to go re-educate them on, because they're discharged with 20 plus medications, right, sometimes. And it's a lot to manage even for, high literacy patients and their caregivers. So those are the first couple services that we began to develop on the clinic side.
Awesome.
How was the relationship there with the physicians? The interprofessionalism and all that, was it pretty solid?
Yeah, honestly, it blew me away. My second day there, the bone marrow transplant director, so physician, the email he sent me was, "Hey, now that you're up and running, this is day 2 of orientation. I'd like you to expand our busulfan pharmacokinetic monitoring program," which, as that's not the topic today, that's uh, pretty involved, complicated. So basically, we do kinetics with busulfan to avoid certain tox. One, because it has very high inter and interpatient variability, and two, if the patients get too great of exposure, or if their AUC is too great, they can experience something called veno-occlusive disease or sinusoidal obstructive syndrome, which has a high mortality rate. So we do kinetics to make sure we aren't overshooting that goal, and then using we have a certain target AUC, and then based on the results we get, we may increase or decrease their subsequent busulfan doses. So we only did that for one of our busulfan containing regimens, and he wanted me to do it for all of them. And he just completely trusted that, I would be able to make that happen. Then the following day, I sat in a meeting where we would discuss ideas as a group. And this was a meeting of doctors, pharmacists, nurses, and mid-level practitioners. And the first thing he did after introducing me was, he said, "Jordan, we've been here, all of us, we either trained at the Cleveland Clinic or we've worked here for, many years. And you've been in a number of different places. What have you seen so far that you think we could be doing better? What have you seen at other places, that you think we could improve for our patients here?" So we generated a couple ideas, and he was 100% on board. Like, okay, let's set up meetings with the ID physicians. Let's talk about changing our antifungal prophylaxis from this to this, and very supportive.
Yeah.
From the bone marrow transplant director and all the other attendings I worked with there. It was a really good relationship.
That's awesome, man.
Yeah.
So I mean, is this kind of like the position you see yourself in long term? I mean, is this stuff that there's no chance you're leaving this kind of a patient's, setting? I mean, do you see yourself maybe like get interested in something else later on, or is this your passion now?
So I love, hematology and bone marrow transplant. The diseases themselves, it's fascinating. There's a lot of very exciting research and new drugs and new procedures and like CAR T cells, which you both have probably heard of, which we're now doing for leukemias and lymphomas. And every week I feel like I get a new article alert of phase 1 trials of they're even looking at CAR T cells in solid tumor malignancy. So it's very interesting. Where my passion comes from it is, especially with my myeloma patients, it's an incurable disease, and the physicians need the patient's medication regimens and disease can get really complicated, and they need a lot of supportive care. So I develop long-term relationships with these patients and help them manage their peripheral neuropathy or their bone pain or any number of side effects that they may have from the disease. So really the greatest passion I have is for those patients and the relationships I build with them and being able to improve the quality of their life for many years. So I see myself, I don't see that dying anytime soon, that passion and that joy. But in my long-term plans, like in the 10-year range, I do think I would enjoy becoming a clinical manager of sorts,
like
being that
role.
voice. Yeah, an administrative role, but instead of, like managing an inpatient pharmacy where much of what you do is, improve operations, like how can we decrease the turnaround time for IV premixes or whatever? How can we get the med to the patient more quickly and stuff like that, which is all very important. I would like to manage clinicians. So, take my experience as a clinician for 10 years or whatever, and use my experience to, advocate for them. And then on the administrative level, help create policies and procedures, that are benefiting them and allowing them to continue to practice at the height of their license while not becoming burnout from all the different things that they're required to do. So long term, I think I would enjoy something administrative with clinicians.
That's cool, man.
Awesome. So what do you say to students or even residents who are about to start or just starting out, not sure what they want to specialize in, would you pitch oncology, or would you say it's a pretty tough, you got to be a certain kind of person to really want to do oncology? Because I know it's a very tough patient population because, like you mentioned, they're very ill, and so
Right.
I'm sure that takes a toll.
Yeah, so I ask a lot of questions, if someone's unsure of what they like. So originally I knew patient interaction was something I really wanted in my job. So I thought the only way to have that was to specialize in AM care. So I had my rotation as a student in AM care, and it was a very strong rotation. I learned a ton, but if I had to talk about diabetes one more day, I was not going to be I was not going to be able to do it. And that's it's just, so like when I was talking about it just wasn't I just wasn't passionate about it. I loved working with the patients. I did get satisfaction from helping them get better control over their blood glucose, or helping patients with their warfarin, manage their clots, or prevent or manage their AFib, et cetera. But I wasn't passionate about those diseases. So I try and ask questions and not ask them what did you like your oncology module? Did you like your infectious diseases module? I try and get to the bottom of what activities bring you joy.
Right.
Because you can do those activities instead. Like if someone had told me at the beginning of pharmacy school that I was going to enjoy bone marrow transplant or even oncology, I would have laughed at them. I had no interest in oncology. I thought it was all, sad stories, chemo, nausea, vomiting, and
Right.
just something I had no interest in dealing with. But the actual day to day, the tasks you do are, I find, to be very enjoyable. So I try and get to the bottom of the activities they want to do, and also sometimes the lifestyle. What are you okay going to your job every day at 6 a.m.? Because some jobs, if you take an inpatient position, that may be required. Are you okay having a weekend rotation of any sort, once a month, every third weekend, et cetera? Well, if not, then maybe inpatient pharmacy is not for you.
Right.
But those are just some characteristics I try and get them to think about. And then eventually, when we get to the oncology part, I do have a lot of, and is it too sad? It definitely can be. I've experienced some heartbreaking stories, but there's a lot of success too, and that's one of the reasons I like bone marrow transplant, is because that's one of the few opportunities in oncology for us to truly cure someone.
Mm-hmm.
Right.
They have a disease of their blood. Well, we give them someone else's blood stem cells, and if everything goes correctly, they're cured. And so and getting letters, from patients who are 5, 6, 7 years out of their transplant, photos with their kids, saying, I wouldn't have experienced all these things in my kid's life, if it wasn't for the transplant and the care you guys gave. Those, provide enough satisfaction and joy to get you through the sad stories. But I don't sugarcoat it though. It can be really tough.
Yeah.
So are you taking students right now on rotation? Like, are you precepting students?
Since I'm newer in the position, I have like 6 months of protected time where they don't want to like put too much on my plate. But that 6 months is going to end in August, right when the new crop of, I think we've expanded to like 38 or almost 40 residents here at
wow.
UNC. And then UNC's College of Pharmacy has changed their model where starting P2 year, you start doing rotations.
Oh,
So we
really?
have P2s, P3s, P4s, PGY1s, and PGY2s throughout the hospital. So starting in August, I will have students, residents, and when I did my residency here, I had students and residents on my rotations as well that I would be responsible for.
That's super interesting. So are the students still having didactic experience within the rotations in second and third year?
Yeah, so starting second year, they kind of, from my understanding, they like split the class into 2 groups. And group A is doing a didactic module while group B is on rotation. And then they flip.
Interesting.
So then when group B is done with I think it's a month, maybe 6 weeks, when they're done with that rotation, they go do the didactic model that the other half of the class just did. And it's like disease groupings of
Right, right.
topics that they cover.
Right.
Yeah. So, but they're still considered, so as P2s and P3s, those are all IPI rotations, even though they may
Right.
have had multiple. So for us as a preceptor, that's like our expectation. We have a different level of, goals that we're trying to achieve with them than we would a P4 or a resident.
Right.
Yeah.
So if you have a student like that comes in, they're like, yeah, I do want to do oncology. I'm very passionate about it. Do you have the talk of, are you ready to work hard? And if you are watching full seasons of Game of Thrones on Netflix or whatever, that's maybe it's not for you. Do you ever have to have that, moment?
Sure. So I'll let them know, like these are the boxes. If you want to be like a specialist in oncology, these are the boxes you'll need to check, and those boxes include a PGY1 in general practice, and then a PGY2 in oncology. And then I let them know kind of what those are like, to get through. And just so that they know, like, this is kind of these are the sacrifices you'll be making. So you'll need to know and beforehand, that you're going to be okay with that.
Mm-hmm.
And that, so it's, I talk about that, but often, the students, I haven't had a student be surprised when I tell them they need to do a residency to do these things.
Right.
Yeah,
they go,
yeah.
I know, you know what I mean? They're like, yeah, I know it's hard. I see the residents, they look, they look stressed or whatever it might be. So, but I do, I try and, so I kind of do the sandwich method where I might be like, hey, here's a dose of reality. This is what it's really like. I guess it wouldn't be, this is more an open face sandwich where I give them like the bad news first, but then I give it, at the end, I'm like, but you are absolutely capable of doing this. If you truly are passionate, like you tell me, that's going to be, the gas you need to get, to push yourself through, these difficult couple years of training. And I let them know, like, not all residencies are created equal. Like you can do a PGY2 in oncology at one institution and another and have very different experiences. So I encourage them to really try and find out what environment they learn the best in. And some people, I have had co-residents that super intense, and like, if you don't know they're scared to not know answers. Like they thrive in that and they love that.
Mm-hmm.
They enjoy it. And it's those type of programs where the preceptors are that way, where they do the best. Me personally, I'm not that way. I need to put, and I knew that, and I learned that, as a student. So I try and get them to, have some introspection and find out, how is it that you learn? What type of environment do you need? And then start asking everyone, any resident you've ever met, any pharmacist you work with, where did they train, and ask them what it was like, and, just to get these honest answers, to try and get an idea of what programs might be best for them, because there's a lot of great programs.
Yeah.
All right, man. Well, do you want to kind of start talking about some mantle cell lymphoma, kind of get into some of the more clinical stuff?
Yeah, sure. Yeah, no problem. And again, any questions or comments, clarifications, please just stop me. I feel like with my patients, I don't get like 2 sentences out before I'm asking them, like, does that make sense? But that's because I'm not sure that I'm explaining it well. So I just want to so if I'm not making sense, just stop me.
Sure.
Yeah, no, for sure.
Awesome.
So, like, will you walk us through real quick, because I know a lot of
Yeah.
people probably aren't really familiar with what even mantle cell lymphoma. Can we start with that? Like, describe like what that is versus other versions?
Yeah. I'll start big, high level view and kind of drill down to mantle cell.
Let's do it.
So, oncology, you could put the type of cancer a patient could have almost in two buckets. One, it's a solid tumor, breast cancer, pancreatic cancer, colon cancer, etc. There's like a physical mass of cells that you can, depending on the staging, they either go in and cut out and or use radiation if it's early enough. And then you have what you could call liquid tumors. So that's your malignant your hematologic malignancies. So that's your leukemias, your myeloma, and lymphoma. Some people may categorize lymphoma as kind of a hybrid, liquid, because your lymph is liquid, but you also have lymph nodes, which are tissues, and you can actually have physical masses. So Lymphoma is kind of a hybrid, but for the sake of this explanation, we'll consider it a liquid one. Then within the lymphoma group, you have two groups. You have Hodgkin's lymphoma, which is just one type of cancer, which when you look at a biopsy of it, there are certain cells, Reed-Sternberg cells, that they look at. It's easily identified and actually has a pretty standard treatment for it and pretty good cure rates. And then you have non-Hodgkin's lymphoma, which gets confusing because while there's only one type of Hodgkin's lymphoma, there are over 70 different types of non-Hodgkin's lymphoma.
Jeez.
Yeah, so there's a lot of them, and one of those types is mantle cell lymphoma.
Right.
So we've kind of drilled down to that. It is, in the non-Hodgkin's, we have indolent or slow-growing lymphomas, some that maybe you don't treat. It's just a watch and wait. It grows so slowly, if at all, you may die of something else before it ever becomes an issue. And then there are very aggressive lymphomas. And mantle cell lymphoma is on the aggressive end. It's not necessarily the most, but it's one of the more aggressive types of lymphoma. It is pretty rare. It represents 6% of all new cases of non-Hodgkin's lymphoma. The majority of patients who get it, the age 68, 69 years, depending on what statistics you look at. So these are elderly patients. And most of these patients are male. Some reports say 3 times as many men get it as women, others say 2. So somewhere between 2 and 3 times more men get this than women do. When the patient is being worked up by the physician to see, what disease they have, they'll look at their chromosomes and look for any genetic changes. And there's a characteristic one that helps us know that it is mantle cell, and it's called a translocation of chromosomes 11 and 14. So in some type of text, it'll be like a little t parenthesis 11 colon 14 parenthesis. So it just means a piece of chromosome 11 and a piece of chromosome 14, they swapped places with each other. The reason this leads to the disease, and it is characteristic of the disease, is that translocation causes overexpression of cyclin D1. Well, so what? You have more cyclin D1. What's the big deal? So the reason that's bad is because cyclin D1 forms a complex with cyclin-dependent kinases, or CDKs, that are necessary for cell cycle growth, specifically in the G1 and S phase. So you have more cyclin D1 around, so it can bind more CDK, so the cell grows at an unregulated pace, which is cancer.
Right.
So that's, as they're working up, they see the translocation 11-14. That's kind of a hallmark of mantle cell lymphoma. And unfortunately, while it is aggressive, this is an incurable type of cancer. So when we're considering treatment options and what's best for this patient, we are trying to prolong progression-free survival, or how long you're alive without the disease, and quality of life. So those are the things we're taking into consideration when thinking about how to treat them.
So at no point these patients don't have a cure available at all right now?
No, currently no cure. Our best chance is get them into a remission and make that remission last as long as possible.
Right.
So yeah, that's the best case for these patients. Yeah. To kind of help us with that, weighing the pros and cons of how aggressive can we be without impairing their quality of life, we calculate something called a MIPI, or that's Mantle Cell Lymphoma International Prognostic Index score. And what this is it's a calculation that puts a patient into one of 3 risk groups. And that risk is risk of death. So you have a low risk, an intermediate risk, and a high. So a patient with a high risk, who maybe is a little younger, in that younger for the disease, 67, 68 range, that's a patient you're going to be a lot more aggressive with than a 75-year-old with low risk. So I won't do the equation because it's kind of complicated, but it looks at 4 variables, which is the patient's age, their ECOG, which is the Eastern Cooperative Oncology Group. basically that's just their performance status, like how sick are they because of other comorbidities, age, and so on.
Right.
It looks at their LDH at diagnosis and their white blood cell count at diagnosis. So you plug in those 4 numbers, it spits out a number, and then depending on what that number is, it puts them into one of those 3 buckets. And then we use that information to kind of guide us, like, okay, this is how, this person has high risk disease or low risk disease, so let's be more or less aggressive. So first line treatment for these patients, they get very intense chemotherapy. Maybe some of the most intense regimens we have outside of bone marrow transplant. So an example would be alternating R-CHOP. So R-CHOP is rituximab, cyclophosphamide, doxorubicin, vincristine, and prednisone. So that's 5 chemotherapy every 21 days. And then the next 21 days, they get something called RDHAP, which is rituximab, dexamethasone, cytarabine, and cisplatin. So they get that alternating for about 6 cycles. So these regimens are highly emetogenic. This is like when you think chemotherapy, the nausea, the vomiting, the hair loss, the mucositis, that's these regimens.
So is that intense of a regimen standard no matter what stage the disease is in, or is that for like the later stages?
This is for high risk.
Okay,
yeah. So this is for patients who have an aggressive. We're being aggressive with this.
Okay.
Yeah. During this, and if you'll allow me, I'll take just a brief deviation to just explain what an autologous stem cell transplant is, because that is part of their treatment. Are you guys okay with that?
Sure.
We will allow it this one time.
Okay,
Just once.
Okay, the court will allow it. Thank you. So during those 6 cycles, the goal is to get the patient into a remission, and then what we will do is we will collect their own stem cells. So these are so at this point, and not just any stem cells, they're hematopoietic stem cells.
Right.
So this is the common progenitor cell that gives rise to any blood and so all your B cells, T cells, platelets, all your white blood cells, all of that come from these hematopoietic stem cells. So they will collect the patient's own stem cells, store them. They'll put them in a preservative and freeze them, let the patient recover some, and then we take them to transplant, where they will receive even more intensive, and this is just 1 round of intensive chemotherapy. So as you both are probably aware, with even the regimens we went over, and like the R-CHOP and RDHAP, one of the major dose-limiting toxicities is myelosuppression.
Right.
We know this chemotherapy kills the cancer, but it also, that doesn't make a difference if you kill away all their white blood cells, then they take so long to recover, the patient gets infected and dies. So that's our limitation from pushing these doses. So autologous stem cell transplant is our workaround with that. So we bring them in, you have to be admitted. They'll get another very intensive round of chemotherapy at higher doses with the intent to completely ablate all of their stem cells and their bone marrow. So all their peripheral cells and their bone marrow, to try and get any little bit of disease that might be hiding out that we couldn't get with the R-CHOP and RDHAP. Does that make sense?
Yeah. And then they take
so
the ones that they've frozen, or basically, and they're going to put, and where do those come from? Those come from the bone marrow, the stem cells that they're taking out and preserving?
They come from the bone marrow, but we mobilize the stem cells from the bones into the peripheral system. We can mobilize with filgrastim, or it's biosimilar Granix, and or chemotherapy, and or plerixafor. So there's some different strategies on how to get enough stem cells out of the bone marrow into the peripheral. Then you send them to apheresis, where they collect off their blood, and then they separate the stem cells from regular cells.
Right. Okay.
So they're admitted. We give them myeloablative, which if we didn't give them their own stem cells, these are lethal doses of chemotherapy. They would not recover their blood counts. They would be transfusion dependent and either die of infection or transfusion complications. But as you mentioned, we'll give them their own stem cells back. Those find their way back into the bone marrow, set up shop, and then they start making their own blood cells again. So this is when we're doing intensive treatment for mantle cell lymphoma. That's kind of the big picture. First, like at diagnosis, you have high risk disease. That's what you're getting. And we know that if you live long enough, which may only need to be a year or a couple years, depending on the patient, you will relapse with this disease. And that's when we get to that situation, if you remember those categories we're considering with the disease, and one of those was that ECOG score. Many of these patients, their performance status has come down quite a bit, and it's very. I mean, they've undergone a lot. So we use less aggressive chemotherapy at this point, maybe bendamustine plus or minus rituximab. That's it. But even with these less aggressive regimens, the response rates are not great. And this is where, so before Ibrutinib, which we'll talk about today, and Acalabrutinib, which we'll talk about today, just to give you an idea of some of the other novel agents, what the response rates were. So idelalisib can be used in this setting, and the duration of response, so how long the patients stayed in remission, was 2.7 months.
Wow.
Yeah, and only 5% of those patients got a complete response. Lenalidomide, or name brand is Revlimid, this is the longest one, was 16.6 months was the duration of response. But the others range from like 3 months to 9 months. Bortezomib, 9 months. Temsirolimus, 6 months. So before the drugs we're going to talk about today, really these novel agents for treating relapsed mantle cell lymphoma were pretty cruddy. They did not do a great job.
So when you have a patient that has only like such a short, I guess, chance of living, like 2 months, 3 months, how do they afford to do that? Like, I mean, who pays? Do they have? I mean, do you have patients that are like it's not worth it?
So these are conversations, and when you say afford, do you mean like financially afford, or emotionally, physically
I'd say
afford?
like financially.
Oh, sure.
If they say this is
Um,
going to give you 2 months, but are they able to do that, or if do they want to do that to put their families in that, or how does that normally happen?
So the physician will have, an open, kind of honest conversation with them, let them know where they're at, and we'll tell them like these are your options. We can do nothing, and if we do nothing, my best guess is kind of these are some of the things that may happen to you over the next months or years, um, or these are a couple treatment options that we could consider, and if you take those, this is realistically what it would look like if you do that. And then there's usually a talk of goals, like what's important to you, what do you want to do. Some patients, it's I want to spend every day I can with my grandkids. Others, it's my so and so's getting married. If I could make it to this date, I'm like, that would mean a lot to me. So like it can sound morbid, but on it, some people, like, they have a date, like, if I 2 months from now, if I can get to that, that's good. That's when my niece is getting married. I need to be there. That's important to me.
Gotcha.
And then after that, we'll consider, so that can get hard. Often social work is involved because, it's tough. If I was in that situation personally, I would, just knowing my own personality, I wouldn't want my family to think I was quitting on them, to ever say no. Like,
Right.
I don't want to fight to try and be around with them. And sometimes it's, yeah, as good as the physician can be to get that family, and often the social workers are amazing, to get them to have these open conversations about what the kids want, what the spouse wants, what the kids want, etc. If they can be honest with each other, that helps a lot. That makes decision making really easy. And then from a financial side, so these medications like lenalidomide, it has an FDA approved indication for relapse refractory. Or sorry, I would need to look to see if lenalidomide actually does, but like Ibrutinib we'll talk about, it has an FDA approved indication for this, so the insurance should approve it.
Gotcha.
It's not off label. So if it's on label, they should be approved.
Gotcha.
Wow. So from during this whole process, if they decided to do nothing or they decided to go through the whole process, generally what can they expect as far as improved survival time?
So with the current, so with these novel agents, the duration of response is not great. They're looking at a few months to maybe at best not quite a year and a half. But that's just duration. That's just how long the disease stays in remission. When the disease comes back, they don't die immediately. But this is a pretty aggressive disease.
Right.
So I would, and this is anecdotal, just thinking about some of the patients I've had, if they aren't treating, they're looking at a number of months.
Really?
And that number is going to depend on just how fit they are. And, and while you could say, oh, you're high risk, not all of these diseases are created equal. Even if 2 patients are high risk, some diseases are just extremely aggressive. And we can look at how well they responded. So if we treated a patient on the first round and their response lasted 5 years, I would actually feel really good about treating them again with a less intensive regimen, because their disease responded to it. We're just going to mix up the drugs they're going to see this time, and they'll probably get another good response from that too. But if they're relapsing months later after this really intensive treatment, you start to get really concerned and nervous about how and if they're going to respond moving forward.
Gotcha. So talk to us about these new agents. Like, what makes them special? What's the data say?
Sure. So I will. What got me looking into this for my own education was so the American Society of Hematology in December they had a meeting, and this is where everybody goes and presents a lot of new data for treating these hematologic malignancies. And there was one where they looked at the initial salvage approach. So basically the first treatment that patients were receiving at relapse for mantle cell lymphoma. And it was a retrospective study, but it was a multi-center study here in the United States. And they looked at patients who either got bendamustine and rituximab, bortezomib with rituximab, or ibrutinib. And they looked at response rate and so on. But the statistic that stood out to me was the 2-year overall survival. So at 2 years, what % of the patients you treated with this are still alive? So for patients who got bendamustine and rituximab, 76% at 2 years are still alive. The bortezomib and rituximab, 65% were still alive at 2 years. And for ibrutinib, 100% were still alive at 2 years.
Wow.
So that, and again, this is retrospective, so the study was not designed to show that, but I looked at that and I got very interested in the role of ibrutinib, because I personally, at that point, I had not seen ibrutinib used a lot in the relapse refractory setting. I saw more bendamustine rituximab. So just a little bit about ibrutinib. It's so the B cell antigen receptor. This is a receptor on the surface of all B cells, and this mantle cell lymphoma is a B cell malignancy. And BTK, or Bruton's tyrosine kinase, is one of the first kinases in this stream of events that happens. So if you can inhibit it, you inhibit all the downstream effect, which stops proliferation, differentiation, and causes apoptosis. So both ibrutinib and acalabrutinib are irreversible inhibitors of Bruton tyrosine kinase. So they are BTK inhibitors. The first study that looked at this at ibrutinib in this setting it's published in 2013, New England Journal of Medicine. But they looked at patients, they gave patients ibrutinib for relapse refractory setting and mantle cell lymphoma, and they saw really pretty impressive results. So the median survival, progression-free survival, was 14 months. So that may not sound, but if you remember, for these other novel agents, some of the median survivals are like 3 months or 6 months. But the median overall survival at 2 years had still not been met. So this was the first study that kind of gave us an idea that ibrutinib could be a really good option in these patients. So I just bring that up for historical perspective. Fast forward to November of last year, and to that point, we have 3 studies that have looked at ibrutinib in this setting. The one I just went over, which is called the SPARK trial, the RAY trial, which was done by Dreiling and colleagues, and a third one I'm blanking on the author. So in November, what they did is they compiled all the data from these 3 patients, because as we said at the start, only 6% of non-Hodgkin's cases are this. So the numbers are really small.
Mm-hmm.
This isn't a cardiology study where we have tens of thousands of patients.
Right.
So we don't really get that statistical power from one study. So in the British Journal of Hematology in November of last year, there was a study published where they brought in all this ibrutinib data in this setting to try and get a better idea of how well this drug works. And it was really positive. So the overall response rate was 66%. The progression-free survival was 13 months, and the overall survival was 25 months. So compared to the other novel agents, it was looking pretty good. What I found to be very interesting in this study, because these are patients in all 3 of those studies that they compiled. These are patients where they got ibrutinib, but this was like the 4th drug they got, right? Like they're not getting ibrutinib right at relapse. This is like their 4th line of therapy. So this study, they broke it down and said, okay, well, let's just look at the patients that got ibrutinib first line and compare it to patients, at first relapse, and compare it to the patients who got it later on. And the patients who had got it at first relapse had the longest progression-free and overall survivals. So to give you an idea, the 2-year progression-free survival, they hadn't met the median yet. So 57% of patients were still alive. Comparing that to, and that's at 2 years, so 24 months. But when they looked at the whole population, it was 13 months. So there's this huge difference in progression-free survival and overall survival if they got it first line. The reason being, so I was digging through the supplementary appendix and looking at some of their other graphs. It appeared, so the same amount when we look at response to the treatment, that you can either get a partial response or a complete response, and both of those mean exactly what they sound like. And in the patients who got ibrutinib at first relapse, they had the same proportion that got a partial response as anybody who had it at second line, third line, or later. So what made that group different was more patients got a complete response. So this study showed that for patients who got a complete response, at 2 years, 79% of them are still alive, and have not progressed, and then 92% of them are still alive. So this is, compared to these other novel agents. So that right there, like I read that and that was very, very impressive to me. So from this data, really what I pull from this pooled analysis is ibrutinib should strongly be considered at first relapse, because at 2 years, 92% of the patients are still alive, and almost 80% of them haven't progressed yet either, because the majority of them got a complete, or not the majority, more of them get a complete response than when you give it later.
And are you using anything along with it, or just the ibrutinib?
Just ibrutinib.
Wow.
So, we'll kind of get into the dosing. It's once daily dosing. It's a pill.
One drug is enough. That's crazy.
Yeah. So, it is not without its side effects. So the most common are diarrhea, fatigue, cough, nausea, and peripheral edema. Those are all in like the 20 to 40% of patients will experience that. And then the significant side effects that we think about with ibrutinib is atrial fibrillation and major bleeding. So this is grade 3 or more bleeding. So in this pooled analysis, about 5% of patients had a grade 3 bleed or worse, and 4.6% of patients had grade 3 or worse AFib. So while it would be great to use this at first relapse for everyone, depending on their history, it really may not be appropriate. If they have a history of AFib or other cardiac issues, I could see a lot of providers just wanting to stay away from this, and doing something like bendamustine and rituximab.
Right. Is the bleeding just related to depleting the platelets?
So that's a good question. So I've read some preclinical data where, they do a lot of different pharmacokinetic analyses, and they put in a lot of different enzymes, different targets, different classes of kinases. And Ibrutinib, while it does target BTK, or Bruton's tyrosine kinase, it targets a lot of other kinases and platelets specifically. And when I say targets platelets, it's not that it targets them for destruction, but it does interact with them to the point where they cannot form the platelet plug.
Right. Gotcha.
So it's not that it causes thrombocytopenia, which it does some. That is an adverse effect, but it also is physically altering the platelet as well.
Gotcha.
And this is a capsule, right?
It is.
Okay.
Yes, it's a capsule.
So these aren't like IV drugs or anything. That's also pretty cool. Mm-hmm. I didn't realize that either, because I'm not obviously in this space. But when I first were looking at these drugs, I'm like, I didn't realize it was an oral dosage.
Yeah. So they are. I'm sorry, looking at that. Yeah. So they come in 140 milligram capsules. So that's something, if you work in a specialty pharmacy, which is where these medications should be dispensed from, the unique thing about mantle cell lymphoma is these patients, the dose is higher than because we use Ibrutinib for other diseases as well, like chronic lymphocytic leukemia, Waldenstrom's, macroglobulinemia, and others. But this is a higher dose. It's 560 milligrams, which is 4 capsules, whereas for the other indications, it's 3 capsules or 420 milligrams. So that's one of the distinctions between with this disease.
Gotcha.
And with any of these, so it can be taken with or without food. I always recommend them to take it to just be consistent with that. If they take it with food, always take it with food. It's dosed once a day. So to try and take it about the same time every day as well. A little pearl, it is a Bruton's tyrosine kinase, but that's just a type of tyrosine kinase. So any TKI, if you ever have a patient on one of those, or you're reviewing their med list, they're coming to fill their Prilosec at your pharmacy, and you're looking on, you're doing a med review and you see any TKI. So these are drugs, they all end in ib. So right. Dasatinib, imatinib, ponatinib, cabozantinib, etc. What I would, and I do this, some of them I have memorized, the ones I see a lot, but there are lots, and we use these drugs in solid tumors as well. I don't use tertiary references for this because I've had instances where it doesn't provide enough data for me to make the right decision. Mm-hmm. Just go to DailyMed.com, where you can search for package inserts, type in the drug, pull up the package insert, and the 2 things I look for every TKI is what is the instruction with regard to food, because there are some that absolutely must be taken with food, and there are many that absolutely cannot be taken with food. And with this being chemo, and whether you do or don't may change the Cmax by 6-fold.
Wow.
So imagine, and again, just like you said, Mike, it is a pill, it's a capsule, but this is chemotherapy. So right. Could you imagine overdosing someone by 6 times of chemotherapy?
Right.
So look for food and make sure they know whether it should be taken with or without. And this one, Ibrutinib, it doesn't matter. But also look for antacids. Mm-hmm. So some of these absolutely must have an acidic environment to be absorbed. So, if they're picking up some Prilosec over the counter or ranitidine, whatever it may be, and you notice that they're on a TKI, look and make sure that that's okay. And often the package insert will have very specific instructions on the timing and administration of these to make sure that there is no interaction.
Huh.
That's good. You said Daily Med, what was the website you gave?
Sure. So yeah, if you just go to DailyMed.com,
DailyMed.com.
um, yep, and it's well, actually, I mean, it's daily. That's what I type in DailyMed and hit enter. It's dailymed.nlm.nih.gov.
Gotcha.
Yeah, so this is kind of, it's almost like a section of PubMed or the National Library of Medicine. But this is just where I search package insert. So you type in the drug, you hit go, it'll bring up all the different options, like if it's the IV formulation or capsule or whatever it may be. They have the PDF and it will give you all the information you need.
Awesome.
I use this all the time, every day. And you get very specific, often you get very specific guidance on what to do. Also with, on how to dose reduce based on side effects. The patient comes in and their platelets were 200, now they're 100. Well, do we need to change the dose of this? Can we continue? Do we need to stop? Do we need to hold? The package insert it'll have a table and just show you exactly what to do for all of these. Those are just things I haven't found in tertiary sources like Lexicomp or Micromedics.
Gotcha. And so even this medication, even if it's by itself, isn't particularly cheap. It's like 15 grand for 90 capsules. But you're saying since it's FDA approved for that, generally the insurances are going to take care of it?
Yeah, for me, what I've noticed is we'll send the prescription to, and because this is chemotherapy, they have to be filled from a specialty pharmacy.
Right.
They almost always require a prior authorization, but usually that's a one-page form that because these drugs have multiple indications. It's usually a one-page form. You put in the patient's information, check off what indication you're treating, and then you send in their most recent progress note from the doctor, which will have their whole oncology history,
right,
and specifically say this is what they're diagnosed with, and so on. You send that in, it should be approved. But just because it's approved doesn't mean the copay will be affordable.
Right.
So at UNC, and this is not unique to UNC, but we have a medication assistance pharmacy team, and that's their job. They look for copay cards, they look for grants, and if necessary, manufacturer's assistance to get these medications so they aren't cost prohibitive to the patient.
Awesome.
Yeah.
So what about the any other agents in that class we need to talk about? Maybe a newer one.
Yeah, sure. So Ibrutinib is the only first generation TKI, and just the last stats, just because this was so impressive to me. The most recent follow-up of all these patients who have been treated with it. The median for patients, and if you may remember, I said that for patients who got a complete response, they do the best. So for those who got a complete response, their median progression-free survival was 46 months.
Wow.
And their median overall survival at 60 months or 5 years had not been met yet. Meaning, at 5 years, over 50% of the patients are still alive, and they're just on single agent Ibrutinib.
Wow.
At 5 years. So that really is, to me, kind of game changing for this relapsed disease.
Now, are they taking that the whole entire time, or is it for a period of time?
Yeah, so that's a good question. It's without interruption.
Gotcha, but just once a day. So
once a day.
Yeah.
Yep. Some patients may have an interruption due to a side effect, but in the study they looked at what they called it like dose. I think they called it dose intensity. Basically, at the end, what proportion of patients are still on full dose? And it was like 95% or 97%. So the majority of patients, they may have an interruption here or there, but the majority of patients stay at full dose. And if they get a complete response, they have really good results.
That's awesome, man. Yeah. That's really cool.
Yeah. Awesome. I'm glad you think so, because I do. Awesome. So yes. So now, as you all may have heard, there is the second generation BTK inhibitor, and that is Calquence, maybe Calquence, I don't know, but it's a Calibrutinib. And you had asked about what is it about Ibrutinib that we have these bleeding issues, and I said that there's a number of off-target effects. Well, acalabrutinib has been shown in preclinical studies to be much more specific to the BTK inhibitor and not have near as many off-target effects as ibrutinib. So maybe we'll see. I'll tell you the stats. But so with that, they were thinking, okay, maybe we'll have less adverse effects than ibrutinib. And also, it's much more potent than ibrutinib. So we get stronger, even though it is suicide inhibition, we get a more potent, I think, duration of response with acalabrutinib would be the thought for it being more potent. So this, just like ibrutinib, was studied in patients who had relapsed mantle cell lymphoma, but they could have received 2, 3, 4 lines of other therapy before they got acalabrutinib. And this was just published, I think, last month. But if you search it's available on their package insert on the Daily Med. It has all of these statistics as well. So the overall response rate this study had 124 patients, which may seem tiny, but that's actually a really good oncology study. And that's a similar size to the ibrutinib studies as well. The overall, so patients who had a complete response or a partial response was 100%.
Wow.
So every patient in this study, regardless of how many lines of therapy they had, at least had some sort of response, which is very impressive.
Yeah.
And as I mentioned before, the ability to get a complete response appears to have a very strong impact on how long your response is, on how long your survival is, because those who in ibrutinib who had a complete response at 5 years, over half of them were still alive. So that is the background. 49 or 40% of patients had a complete response with acalabrutinib, so which was higher than ibrutinib.
Right.
And I know you guys said you don't like to change the editing of this, but I just saw that I misspoke. The overall response rate was 81%, not 100%. So sorry, but that's still much higher than the 68% of ibrutinib.
Yeah.
So
yeah.
81% versus 68. If you want to go back and fix that, that'd be great. But I don't mind. Looking like a goof. So yeah, more patients had a complete response. There was a greater overall response rate as well. It had a similar side effect profile from the most common ones. So patients still had headache, diarrhea, fatigue, and myalgias, similar to ibrutinib. But what was unique, if you'll remember, if you look in the package insert, which looks at ibrutinib not just in mantle cell lymphoma, but in any disease it's treated for, the incidence of AFib can be about 9%. So almost, 1 in 10 patients
Right.
almost can have, and that's grade 3 or worse AFib. That's not just any AFib. In this study, there were no cases of atrial fibrillation.
Really?
Yeah, there were none. However, just like the package insert for ibrutinib kind of pools it all together, they did the same type of study with acalabrutinib. So they pooled all the data for all the different diseases they're testing to treat it for, to see if there was AFib, and it looks like the incidence is about 3%. So it's still, it's there, but it's less
Right.
than ibrutinib. And they also think this has to do because it's more specific for BTK and doesn't have the off-target effects. The other scary part with ibrutinib was the bleeding. In this trial, there was only the only bleeding cases they had were contusions, which 13% of patients had, and some petechiae in 9% of patients. They did have one grade 5, which is a death adverse drug event, but it was a patient who had a history of aortic stenosis, and that's what he ended up dying from.
So they didn't contribute that to the medication?
They did. The independent review they reviewed the case, and they did not attribute it to acalabrutinib. So really the kind of take home from acalabrutinib, we don't have as much data. We have the one trial in mantle cell lymphoma, but it had a greater overall response rate. More patients got a complete response, which I would then, it has the same mechanism of action as ibrutinib. it should also translate into a greater proportion of patients having longer overall survival. Over 5 years. Compare if it's similar to Ibrutinib, which I think it's probably better. Couple differences is it's dosed twice a day and not once a day.
Right.
But it can be given with or without food, with or without respect to antacids.
Okay.
Yeah. So these are some of the, so it can get kind of tricky with the ones, especially with the antacids, because you have a patient with a history of GERD or something else, and there's some clever ways to get around it, but that's not something we have to worry about with either of these.
Huh. That's awesome. And just so y'all know, this is an AstraZeneca medication, and it looks like it just came out like last October of 2017, right? So hot off the presses.
It got accelerated. They applied for fast track application, like accelerated approval, like there's like 2 or 3 different things you can apply for with the FDA to get your drug approved as fast as possible, and they got all of them.
Oh, really?
With this medication. But it's based on this data that was presented at the ASH meeting in December and then published in January.
Wow.
So so it's been approved since October. I have heard patients both at the Cleveland Clinic and here, physicians working on getting their patients, not a ton, because again, not a ton of patients have mantle cell lymphoma, but physicians were really eager to start getting this for their patient. They were really excited about it.
Yeah, that's awesome. It sounds like it's very promising, and for a pretty awful disease might be able to make it just a tad bit better than what we've had before.
Right. And if you think, these, the patient's median age of diagnosis is 68, say they got, they had intensive induction and transplant, had a remission for 4 years, so now if they were 68, they're 72. And then this drug gives them 5 or more years, they're approaching, the life expectancy that they would have had regardless.
Yeah.
So, it may not sound like oh, we're only giving them 5 more years, but these are already pretty elderly patients.
Right.
So,
right.
5 years is a heck of a lot better than 2 months or whatever the other drugs were.
Yeah.
Right. Yeah, exactly. Yeah, exactly. Yeah. Adalasib, I think, is 2.4 months.
Wow.
That's crazy.
Yeah. Yeah. Well, I've never seen it used in this case, but for that reason. Yeah.
That's good.
Yeah.
So what else is in the pipeline? I mean, have you looked at some of the drugs coming out, or are they even phase 1? I mean, do you think that there's like a cure like on the horizon, or are they at least getting a lot better at it?
So I don't see a cure, because I mean, while the drugs, the 2 we just went over have good response rates, and for those who get a complete response have long overall survival, we know that intensive regimens at the start, that those are better, and even though we're throwing that stuff at them, they're still relapsing. So I don't see a cure. Potentially, actually, I don't know if that's a cure. So the newest thing might be CAR T-cell therapy, which, are you guys familiar with CAR T-cell or?
I've heard of it.
Heard of it.
That's about it.
I couldn't walk through it or anything.
Okay, so it stands for chimeric antigen receptor T-cells. So essentially what they do is you pick a target, which is usually some marker like CD20, CD38, CD something, that's on the disease you're interested in. And obviously you want to pick a marker that's only on that disease and not on other cells that you're not trying to target. And then they take the patient's T cells, you send them to the company, and they genetically modify their T cells to express receptors that will recognize that marker on cancer. They send it back to the patient, we infuse it in there, and basically you've just given back the patient their own immune system that now recognizes their cancer and goes and kills it.
That's crazy.
So this is like the newest, cutting edge, sexiest thing going on in oncology right now.
Man.
Currently there's an approval for this type of treatment in acute lymphoblastic leukemia and B-cell lymphomas. But so that's potentially, but the data is young, so I don't know. I wouldn't be able to predict, kind of what that's going to really do for this disease, but it's exciting and promising from as far as a cure goes. As far as other BTK inhibitors, there's one currently it's just, the letters and numbers, BGB3111. There was some data on it presented at ASH, and it didn't look a lot better than Ibrutinib or Acalabrutinib, but it was studied in patients not just with mantle cell lymphoma, but also diffuse large B cell, follicular, and marginal zone. So it's really, and they didn't tease out the responses by individual diseases. So it looks good enough that I think they'll continue to study it, but I don't have a good idea of, if I think it's going to be really good for mantle cell. What I'm most excited about actually is, going all the way back to the beginning and considering what do we do for our patients who can't handle this really intensive therapy. There are a number of trials that are looking at our less aggressive therapies like bendamustine and rituximab, and pairing those with Ibrutinib or Acalabrutinib. So based on the results, of how long people's response is lasting in the relapse setting, I think you pair one of these drugs with two drugs we know respond, that the disease also responds to in the frontline setting. I think, especially for our elderly patients, that it's a potential really tolerable treatment regimen that will give them a response that will last, long enough to where we don't have to worry about them relapsing. That it's by the time they're relapsing, we're not. They're getting old enough that they're having to deal with other issues, or may pass away from other concerns.
Right,
so
right.
I'm really excited. There's a number of trials looking at setting these drugs in the frontline setting with our standard chemotherapy. And I think for our elderly patient, our non-transplant eligible patients, I think that could be extremely beneficial for them.
Yeah, awesome. Cool.
Yeah.
That's cool, man. So kind of in closing, what are some resources, what are some things that students can use if they are interested in learning more information, or what guidelines should they use? Any apps, anything like that they can use in day-to-day?
Sure. So NCCN, the National, I think it's Cancer Care Network, go to their website. And they have guidelines for everything, for all diseases, and they are very extensive. It does require you to create an account, but it's free, and they don't spam you with anything. So you have to give an email, you make up a password, and I've never gotten an email from them. Oh, the only emails I get from them, which I signed up for, is if any guidelines ever update, they send me an email saying, hey, we updated these guidelines if you want to look at them. So NCCN is really good. If you're interested in transplant at all, let me look on my phone actually, so I get the name of it right. There is an app called BMT Guide, and this is something done by Be the Match Foundation, which is an organization that helps find matches for bone marrow transplant. I don't know if you've seen these things on Facebook, Lemons for Leukemia. People are like eating, it's kind of like the water bucket challenge, but instead of a water bucket, you got to eat a lemon, and it's to raise awareness. I'm going to be doing something with that. I was challenged by the residents here, myself and the other hematologic pharmacists. So we'll be doing that, but I'll put a little plug in. Go to their website and try and find a place. They'll send you a kit to do a little cheek swab at home, to add yourself to the registry to become a bone marrow transplant donor. It may sound scary, but honestly, they're not going into your bones. It doesn't require surgery. They give you some little shots you do in your belly, like insulin, and they'll collect your stem cells, and you can this is one of the rare opportunities that you could cure someone for cancer. I had a co-resident. She was selected to be a donor last year during residency for a young man in Canada, and it was one of the best experiences of her life. I'm a donor. I really hope one day that someone will find me as a match. I'd be happy to do that. So go to their website. They'll send you the kit. It's free, and you could cure someone from cancer.
That's awesome, man. The website's BMT Guide.
So Be the Match is the name of their organization. Gotcha. Yeah, the name of the app on the iTunes store is BMT Guide. some other apps. I have ASBMT is the American Society of Bone Marrow Transplant. If you're interested in that, they have a number of guidelines as far as what do we transplant and why, what the survival rates are, stuff like that. The CDC has a nice app. So if you want a nice little vaccine schedule for kids, adolescents, catch up, adults, whatever, they have a nice interface. That's an app I use occasionally. And the DailyMed website for package inserts, that's one I use a ton. All of these are free. None of them require any sort of paid subscription or anything like that.
Okay,
Awesome.
and I do have a quick question then for any of our community folks that are listening, watching this. What vaccines obviously we know live vaccines, if you're immunocompromised, we're not giving patients, but what about non-live? Because that's some of the big debate I've heard between community pharmacists is they don't know whether or not to vaccinate. They always say talk to your oncology team. What's your thoughts on that? And is that really just the best advice to go ahead, or are they using over precaution or what?
Sure. So the data are not great as far as, because the two concerns are, is the vaccine you're giving to the patient going to hurt them? And then two, if it's not going to hurt them, do they currently have a robust enough immune system that they're even going to mount a response? Right. So like with these lymphomas, they're B cell malignancies. So if you don't have B cells or they're severely depleted, give yourself a vaccine. Are you really going to develop the antibodies you need to fight off? And then you mark in that person's medical history, they're vaccinated against shingles or whatever it may be, but they're really not. So those are kind of the two debates. So I would always, tell them to talk with their oncologist, but for your own education, the ones you will see given commonly and that are, there's some good data to recommend, is the seasonal flu vaccine and pneumonia.
Okay, gotcha.
Because so those are the two that I wouldn't be surprised to see the patient still getting. There actually are some guidelines like at diagnosis where they say get your pneumonia vaccine right now before they give you the chemotherapy, because they know that will be beneficial for you.
Right.
Definitely avoid all live vaccines. The one that's going to be interesting, and you probably both are aware of the vaccine Shingrix. Mm-hmm. So the new shingles vaccine that's attenuated. I just downloaded yesterday some phase 1, phase 2 data of using that vaccine in myeloma patients. So I need to personally review that, but I've heard my providers starting to talk about it with their patients, that it's something they're most likely going to be receiving earlier. Because currently we just give them prophylactic Valtrex, so they have to take 500 milligrams of Valtrex every day to, prevent reactivation. But if we could give them this vaccine, that would be great.
Yeah, for sure. I'm really excited, and for HIV patients too. I'm excited to see if this one's going to be a lot more effective. So Shingrix is a game changer for sure in the vaccine world.
Yeah, so I agree. So that's some weekend reading I have for myself, that myeloma data with Shingrix. So
party.
Yeah. My wife's out of town, if you couldn't tell. So
that's awesome.
That's funny.
Yeah.
Well, Jordan, man, I really appreciate you taking so much time with us. I learned a lot too. That was great.
That was great.
I know you're a busy guy, so I appreciate you taking the time to do this.
No problem. It's awesome what you guys are doing. Anything to, help people be interested in oncology or just feel more comfortable with it or anything like that. So if you, if you guys know anyone interested in this stuff, in oncology or residency or whatever, you guys can always send them my way. I'd be happy to chat with them or, pick their brain, let them pick my brain, whatever it might be.
Sure.
So that was actually perfect. That was my next question. So if a student has questions, Instagram is the one that we have the most followers on, but there's, thousands of them on there. So if I have someone that wants to reach out and talk to you, how would they contact you?
Yeah, so if you want to contact me on Instagram, that's fine. I'm confirming on my phone right now that I even know my name on it. Like I look at a lot of pictures on Instagram. I haven't posted in a little bit, but I do look at it every day. So my Instagram it's Bowtied Farmer. So that's BOW_TIED underscore, and then farmer, but with a PH, because that's clever, I guess.
Yeah, got to do that.
So yeah.
I
So
get it,
that's on
like a pharmacist.
Instagram. Yeah.
Oh,
Yeah,
that's why.
exactly. Yeah, now I get it. So yeah, so you can follow me or send me a message on there. And then if we need to connect via email or phone or whatever from there, we can get information, on through the direct message on Instagram. I'm also, if they use Twitter, I have a professional account that I use just for, retweeting stuff from or reading stuff from like New England Journal. And that's another thing that this was huge at the Cleveland Clinic. Like I had been there a couple days, and one of the doctors, I was getting to know him, and he's like, "Oh, I actually just read your Twitter profile, and it still says that you're at the University of North Carolina. You need to update that and say you're at the Cleveland Clinic." Like the docs there were tweeting stuff, and it's all professional. It's all clinical trials. It's their opinion on
that
how
warms my heart.
should or should be treated. But yeah, so if you want to follow me on that Twitter, it's a J Miller PharmD. So you can direct message me or at me on that either.
They had a doesn't Cleveland Clinic have an Alexa briefing as well for Amazon's Alexa?
Yeah, actually, I think I do. I think I heard an advertisement for that when I was listening to the radio the other day. They're very so technologically advanced is like, I don't know, an understatement. They have, like, everybody here is really excited. We have a couple robots that are like delivering medications and stuff around the hospital. Cleveland Clinic probably has hundreds that I mean, it's like they have like their disposal system and a bunch of services, like essentially like 2 humans run it and like hundreds of robots that just like take stuff around, and the humans like make sure anyway. So yeah, I wouldn't be surprised if they're on Alexa, Apple HomePod, and a bunch of other stuff. They're really into technology.
So when can we expect to see the oncology Alexa flash briefing from you?
Oh man, I think I still need to educate myself a little bit. I did finish a resident, but there's so much to learn. As there's, especially in my new position covering lymphoma too, over 70 different types. I still got a lot of reading, so maybe
sounds like
maybe a few years.
Sounds like you know what's going on a lot better than I do. So that's awesome, man. You walked us through it in a really, I think, logical, easy to follow way. So that's great.
I'm glad to hear that. I hope I wasn't speaking too fast, and people can follow along.
No, that was great, man. Thank you. And we're gonna talk afterwards, and we're gonna get you set up with Alexa and get you approved by Amazon, so I can start hearing you every day. If mine can be on there, yours can definitely be on there.
All right, sounds good.
All right, Jordan. Thanks for joining us. We will talk to you next time.
All right, thanks, guys.
Thanks.